Good morning, everyone. Hi, I'm Stan Strumfeld. I run our programs and fellowships and this internship here at the Rockefeller Institute of Government. The Center for Law and Policy Solutions internship is a semester-long program where we have interns come and work on a public policy project over the course of the semester with our researchers here. They do all the research, they do all the writing, put this presentation together. This is an incredible group of students. They have worked so hard on a very challenging topic. They're going to present an incredible presentation for you today and open it up for questions at the end. So thank you so much for being here, and we'll let them take it away. Thank you.
Good morning, everyone. Today, we will be presenting our research on the maternal health crisis, maternal health care facility closures, and their impact on medically underserved populations. My name is Ashley Bostic, and the three of us here today have had the opportunity to work for the Center for Law and Policy Solutions here at the Rockefeller Institute of Government. I am a sophomore at the University at Albany, majoring in political science and sociology, and now I'd like to give my fellow interns the opportunity to introduce themselves.
Hello, everyone. My name is Karina Cruz. I am currently a junior at the University at Albany, and I'm majoring in communications.
Hi, everyone. My name is Anaya Dingle. I'm also a junior at the University at Albany, and I'm a political science major, public policy minor.
With that being said, we're going to begin our presentation, starting with the overview.
Across the United States, healthcare facility closures have become increasingly common, particularly impacting birthing people's access to maternal healthcare services. This growing crisis worsens health outcomes of medically underserved populations or people who have limited access to healthcare services. These vulnerable communities include people in rural areas, people of color, and low-income birthing people, referring to people who carry a baby, including cisgender women, transgender, and non-binary individuals. These populations experience diverse cultural, financial, and/or geographic barriers to accessing care. Our research examined this national trend of healthcare facility closures disproportionately impacting the availability of maternal healthcare services for medically underserved populations. We utilize this term, maternal healthcare services, because it encompasses services provided through hospitals, maternity wards, obstetric units, and birth centers.
Pregnant birthing people are in a unique position as they require consistent prenatal services throughout their pregnancy. Geographic disparities for medically underserved populations heavily influence the availability of maternal care facilities. Existing research has examined the impact of maternal or maternity care deserts, which are counties where there are no birthing hospitals, birthing centers, or obstetric care units. Our research showed that birth centers have improved health and birth outcomes, especially for communities of color. Birth centers heavily accommodate midwives, which are the healthcare providers trained to provide obstetric and gynecological services. Birth centers also provide doulas, who are non-medical professionals that provide emotional and physical support to birthing individuals throughout their pregnancy. These forms of care tend to decrease the risk of preterm, low birth weight, and C-sections, especially for Black women.
Since the 1940s, birth centers have played a vital role in promoting positive health outcomes for birthing people, particularly those from low-income and medically underserved areas. Unlike general hospitals or facilities, birth centers are designed specifically to meet the complex and multifaceted needs of pregnant individuals. They often offer access to midwives, doulas, lactation consultants, and culturally competent care. All of these services are critical in reducing stress, improving maternal health outcomes, and lowering rates of complications. Beatrice Borders, a state-licensed grand midwife, operated one of the first freestanding birth centers in 1949 in Georgia. It served over 6,000 Black women in the Jim Crow South who had no access to hospital or medical care. These early versions of the birth center model were called a maternity home or nursing home, and they were born out of the necessity to care for a long-standing medically underserved population.
And to emphasize our research here on a local level in upstate New York, we conducted a case study of Burdett Birth Center, which is the only birth center and birthing facility here in Rensselaer County. Burdett serves numerous medically underserved demographics within the capital region, offering a focus on midwifery and doula care. It faced closure in 2023, but was ultimately preserved through community action and state funding. This case study helped us to examine the impact of both maternal health care closures and the significance of birth centers for communities of color, which we'll discuss later on in our presentation.
Within the vast U.S. healthcare system, maternal healthcare facilities are heavily underrepresented. The United States healthcare facility landscape comprises approximately 238,000 healthcare facilities, including about 6,000 hospitals, 400 birth centers, and 1,400 health centers. These facilities offer maternal care to over 30 million residents in America across all U.S. states and territories. Within maternal health care being provided within such a small fraction of the healthcare system, these services are disproportionately available to millions of people, many of whom belong to existing marginalized communities.
A significant portion of the U.S. population resides in medically underserved areas. In fact, one in every 10 birthing people live in underserved areas with limited geographic access to essential resources and services, often leading to the creation of maternal care deserts. These deserts house over 2.3 million reproductive aged birthing people. The limited availability is further strained by the continued closure of maternity care providers and facilities nationwide.
Over the years, there's been an increasing number of closures of maternal health care facilities within the nation. 400 maternity service providers have closed nationwide between 2006 and 2020, an average of around 26 closures every year. This year alone, there's been 37 closures. This growing scarcity not only blatantly impacts birthing people's access to maternal health care services, but also impacts their ability to navigate these closures and reveals a much deeper issue of unequal access to obstetric care across the country.
Access to obstetric care is also unevenly distributed across the U.S., with 52% of counties lacking hospitals with an obstetric unit. Moreover, 35% of all U.S. counties are maternal care deserts, with around 1,100 areas exhibiting limited access to maternal care services through healthcare facilities. Between 2022 and 2024, there were 25 obstetric units in America that have closed services. For the many affected medically underserved residents of these deserts, there is not a single obstetric clinician or birthing facility within their county. In 2024, more than 150,000 babies were born in maternal care deserts. This data highlights the necessity of maternal care providers, such as birth centers, to fill the gap.
Maternal health care facilities provide vital and specialized services to their patients. Services include educational programs such as self-care or self-help, routine laboratory exams, health counseling, prenatal and postnatal care, breastfeeding support, family planning, and more, depending on the type of facility. Birthing centers specifically focus on low intervention natural births and often provide more choices on where and how to give birth. Many birth centers are freestanding, which means while they are not part of hospitals, they are partnered with local hospitals and doctors in the event further specialized care is necessary. Access to this range of specialized health care is vital for individuals who need to be prepared through their pregnancy and delivery. This is not only for the safety. Consequently, there becomes a rising concern when these resources are facing widespread instances of closures throughout the country.
And so when conducting our research, we approached it with this question: how do these areas and populations become medically underserved? These areas are described as a shortage of primary healthcare services for residents within a geographic area such as a county, a group of neighboring counties, a group of urban census tracts, or other geographic areas. Medically underserved populations could be classified as such when the designation criteria is met, including being within a rational service area such as a county or a sub-county, having a percent of the population at or below 100% federal poverty level, having a percentage of the population greater than 65 years old, or the infant mortality rate of the area receiving an index medical underservice composite score of less than 62. These qualifications also allow for future incentive for federal funding for healthcare services, which we'll go on to analyze later within our possible solutions section.
There are several causes behind maternal healthcare facility closures, creating a direct and disproportionate impact on medically underserved populations. The largest cause of closures stem from the high cost of providing care due to low health insurance reimbursement. In 2020, Medicaid and Medicare underpaid hospitals in rural areas by a total of $5.8 billion. This places a massive burden on their operating margins. Running maternity wards places a significant burden on healthcare facilities, often threatening their sustainability. This is due to the high staffing and resource costs, inadequate insurer reimbursement, and limited public health coverage. Operating a maternity ward comes at a high price, often posing the largest barrier to healthcare facilities remaining open. Hospitals must maintain a 24/7 staffing ward with specialized personnel and equipment. Health insurance, despite covering a portion, often fails to cover the full cost for providing maternity care.
Hospitals with low patient volume are forced to accept low reimbursement rates, or else they're left out of plan networks entirely by commercial insurance providers. With their lack of market power serving a smaller population, they are forced to take it or leave it when large insurers refuse to negotiate higher reimbursement. For those covered under Medicaid, this coverage is even further limited. Medicaid reimburses New York State hospitals 70 cents for every dollar spent by facilities providing care. Consequently, healthcare facilities are forced to take on the financial burden of the uncovered amount. Therefore, rural areas, accounting for 2/3 of all maternal care deserts, are put in a complex position of having to continue to provide services that are consistently underfunded.
The cost of these services encompassed within providing essential maternal care places the vital resource further out of reach for these medically underserved populations, which directly contributes to reduced access and worse outcomes when providers in these areas are forced to close. As the financial strain continues to grow, many hospitals are left with no choice but to reduce or eliminate maternal services entirely, leading to more widespread closures and service consolidations, especially in underserved rural areas. The choice to consolidate is typically made by hospital administrators or the parent health system. Consolidating maternity wards would remove them from one location and allocate resources for its continuance in a farther facility. Effective this year, several more facilities are set to terminate their labor and delivery departments, and by the end of 2025, more than 50% of our country's rural health facilities will no longer offer labor and delivery services. This data begins to display how the consolidation of maternal health care facilities can further lead within assisting in the development of an area becoming medically underserved.
This pattern of consolidation and closure not only limits access to healthcare, but also contributed directly to the rise in medically underserved areas, a trend which was further intensified by COVID-19 pandemic. Before the pandemic, over 50% of rural counties nationwide lacked hospital-based obstetric services, largely due to persistent negative operating margins, staffing shortages, and systemic underinvestment. Although federal COVID-19 relief funds provided temporary financial relief, they did little to reverse the trend of maternity unit closures. Instead, the pandemic exposed and accelerated the erosion of maternal care access, especially in medically underserved areas. As maternity services continue to disappear, the medically underserved populations are confronted with the biggest impact.
Access to maternal care is further diminished by the bystander effect, a term which refers to the strain taken on as nearby hospitals absorb the increased patient load. Hospitals within a 30-mile radius of a closed facility have seen surges in patient volumes, elongating patients' wait time, and often lowering the quality of care and health outcomes for medically underserved people. One study of 93 bystander hospitals found that emergency department visits increased by 10.22% within 2 years of nearby hospital closures. Closures force patients to travel farther for care, which is especially difficult for low-income and Medicaid-covered individuals who may not have access to adequate modes of travel.
The United States has shown alarming increases in maternal morbidity and mortality rates. Pregnancy-related deaths in the United States increased from around 7 deaths for every 100,000 live births in 1987 to 33 deaths for every 100,000 live births in 2021. The trend hit maternal care deserts especially hard. The risk of pregnancy-related deaths increased in these areas by 91%. For women who are living in maternal care deserts, they are now facing a 13% higher risk of preterm birth. Several different populations are directly affected by these closures. Within our research, we looked at those in rural communities, women of color, low-income populations, and individuals on Medicaid.
Rural communities are especially impacted by maternity ward closures due to their already limited access to even reducing further health care. These closures contribute to a 0.5 annual employment decline and drop in housing. These closures contribute to a 0.5 annual employment decline and a drop in the housing demand, discouraging any new residents. Industrialization and geographic isolation worsen this issue. This is followed by a population decline driven by a reduced birth rate, aging populations, and migration to urban areas. This results in lower inpatient volumes, making healthcare facilities less sustainable. This process is a result of maternity ward closures, which causes a rippling effect, circling back to more closures occurring within rural areas affecting rural communities.
Women of color are also affected by these closures due to pre-existing health disparities, which increase the risk of adverse maternal and infant outcomes. While these conditions impact multiple demographics within medically underserved areas, they disproportionately impact Black women, who already face worse health outcomes. When hospitalized, 1 in 10 Black mothers report that they were treated poorly due to racial biases, compared to just 3 in 100 white mothers. Additionally, Black women are also 3 times more likely to die from pregnancy complications than white women. In maternity care deserts, these conditions are only worsened, where nearly 15% of babies born to Black birthing people are premature. This has led to an estimate of 60 to 80% of Black maternal deaths being deemed preventable, including those caused by preeclampsia or hypertensive pulmonary disease. Preeclampsia, a pregnancy complication blood pressure, has a 60% higher rate in Black women in the United States than white women. Moreover, hypertensive pulmonary disease, a condition that affects the blood vessels in the lungs, observed notably higher rates among Black women, who experienced a 21% increased need for hospitalization. These disparities highlight the compounded effects of systemic racism and lack of healthcare facility access for Black women.
In addition, low-income populations are also disproportionately affected when they lose access to maternal care. These closures further increase the issue of affordability to medical services by hindering access to prenatal, delivery, and postpartum care. Longer travel times, delays in accessing emergency maternal care lead to increased health risks for both the birthing person and the baby. Expenses naturally arise for low-income individuals when maternity ward closures occur, creating further barriers to accessing these services and more difficulty in navigating them for those that are struggling financially. Lower income individuals are also more likely to be on Medicaid, leading to the next demographic within underserved populations.
Finally, maternity closures impact medically underserved populations of those on Medicaid. People on Medicaid depend on public assistance programs for healthcare, and these closures lead to financial loss attributing to the lower reimbursement rates from insurance providers. This medically underserved population is directly confronted with this issue when they seek medical treatment and are met with the reality of not being able to cover the difference of their medical bill.
Legal and political shifts, such as overturning Roe v. Wade, have also further compounded the challenges facing maternal health. In 2022, the Supreme Court overturned Roe v. Wade in a decision made through the Dobbs v. Jackson Women's Health Organization case. This decision has widespread effects on communities across the U.S., particularly in states that enacted strict abortion laws. These restrictions, such as the Texas Senate Bill 8 and trigger laws in several southern and Midwestern states, have severely limited or eliminated access to abortion services. This has disproportionately impacted low-income, rural, and marginalized communities who already face greater barriers to traveling for care.
These restrictions have also strained maternal health care systems, with some hospitals and providers reducing or closing services due to legal uncertainties and fear of criminal penalties. In turn, this has led to higher health risks for pregnant individuals and worsened maternal health outcomes in the affected regions. This information was significant to our research because it displays how these legal decisions, restrictive policies, alongside systemic issues like facility closures, disproportionately impact medically underserved populations by limiting their access to maternal health care.
To study the potential impacts of maternal health care facility closures on underserved communities, we conducted a case study on the Burdett Birth Center. The Burdett Birth Center is a maternity care facility located within Samaritan Hospital in Troy, New York, of Rensselaer County, and it is operated by Trinity Health. Established in 2011, Burdett was created through the merging of two Troy hospitals within the St. Peter's Health Partners Network. It offers a range of services including prenatal care, labor and delivery, postpartum care, and lactation support, serving families across the capital region. In recent years, Burdett has faced the threat of closure driven by financial pressure and broader systemic issues affecting maternal health care facilities nationwide. Its potential loss sparked significant community advocacy, highlighting the essential role that facilities like Burdett play in ensuring access to maternal health care.
Burdett is important to the surrounding community for 4 key reasons. Firstly, Burdett is the only birthing center in Rensselaer County, which is home to approximately 159,000 people. It also serves other nearby rural counties, including Washington County and Columbia County, each with around 60,000 residents of their own. Rensselaer County is a mix of rural and urban communities, low-income populations, and women of color.
Secondly, Burdett provides critical services to these communities. Burdett provides a variety of services ranging from anesthesia and nitrous oxide for pain management, hydrotherapy, including water birth, as well as vaginal birth after C-section or VBAC delivery. Furthermore, Burdett values patient autonomy and allows expectant parents to choose the type of pregnancy care and delivery that they want. Patients can select from Burdett's collaborative model of care, which includes the obstetrics program or a more personal and natural experience with their midwifery model of care. Multidisciplinary or collaborative care refers to different healthcare professionals working together to support the same patients. Within pregnancy care specifically, studies have shown that including providers like midwives, doulas, and lactation consultants help lower the risk of birth complications and lead to better health outcomes for both parents and babies. Burdett's collaborative care model has been statistically proven to produce better birth outcomes for birthing people and babies, with Burdett's cesarean rate being 15% on the whole and 8.9% for Capital Region midwifery specifically.
One part of the collaborative care model, the licensed midwives, provide primary health and wellness care to women of all ages, including the following services: pregnancy, childbirth, and newborn care, preconception counseling, annual health exams, gynecological care, and screening procedures, and additionally, family planning. More specifically, licensed midwives provide complete care for a birthing person throughout their entire birthing experience. New York State Assembly member John McDonald, who represents Rensselaer County, says, quote, "The midwife-centered care provides a longer bond and a closer relationship with the patient, which usually leads to better health outcomes for mother and for child," unquote. 44% of births are attended by midwives at Burdett, while other Capital District hospitals have few or no midwives attending births. At St. Peter's Hospital in Albany, that number drops to 16.6%. At Bellevue Women's Center in Niskayuna, it drops even further to 3.2%. And at Albany Medical Center, they do not have one single practicing midwife in their entire birthing facility. Birthing centers are also well-versed in providing specialized support across various birthing populations, including pregnant teens or older birthing people, which are now lacking in these surrounding facilities. The obstetrics program has obstetricians who are board-certified specialists. Convenient access to essential prenatal services like blood work, glucose testing, and ultrasounds within the same facility streamlines care. In the event of complications, patients are connected to a vast specialist network, including the region's only Level 3 NICU for advanced newborn care. The program was recognized nationally for excellence in nursing and safe delivery practices.
Additionally, Burdett stands out from these other nearby maternal care providers because of its openness to doulas and supportive birth practices. Much of Burdett's importance lies here within the fact that doulas are often not allowed or limited within hospital settings. Ashley Sopp, who was a leader within the Save Burdett Coalition and a mother who gave birth there at Burdett herself, recalled a time where she talked to a Black mom who chose specifically to go to Burdett. Sopp stated that, quote, Burdett was the place where her doula was actually able to be there and support her partner in the room, unquote. She elaborated further that, quote, the mother couldn't do it at St. Peter's. They wouldn't allow it, unquote. These facilities also streamline care by centralizing essential resources under one roof, ensuring timely and coordinated support during labor and postpartum.
Research has also highlighted the important role of doulas in promoting health equity for Black, Indigenous, and people of color, or BIPOC, both because they advocate for birthing individuals and because greater proportions of doulas are BIPOC compared to the other birth care providers. Lastly, Burdett Birth Center primarily serves marginalized and medically underserved populations. It delivers up to 1,000 newborns annually, with more than half of its patients covered by Medicaid, and approximately one quarter identifying as people of color. According to the community-led Health Equity Impact Assessment conducted by the Save Burdett Coalition, 55% of births at Burdett are covered by Medicaid, compared to just the 33% at St. Peter's Hospital. Moreover, Rensselaer County, City of Troy, Green Island, and Watervliet have amongst the highest percentage of their population who are Hispanic, Latino, and Troy has the highest percentage of its population who are Black and African American at 16.4%. There is a critical overlap between these two populations at Rensselaer County residents who are There is a critical overlap between these two populations, as Rensselaer County's residents who are racial and ethnic minorities have a much lower per capita income on average than white residents of the county. In short, the importance of Burdett lies within its position as the only birthing center in Rensselaer County and its ability to provide accessible, high-quality maternal care to low-income patients and people of color.
And so this is why Trinity's announcement to close the center in December of 2023 ignited such strong community opposition. Burdett's proposed closure was linked to numerous financial reasons. An interview with Kristen Musatelli, Vice President of Population Health and Advocacy of Trinity Health, revealed that Burdett operates at an annual cost of approximately $2 million. This includes staffing costs for days when no births occur, leading Trinity Health, its parent organization, to argue that the center was financially unsustainable. Musatelli captured this conflict perfectly with this question. She highlighted during our interview, quote, "What would you guys do if you had a service where there's literally nobody using it? Nobody is going to the service, you don't have any babies on that unit, and you're forced to staff it 24/7 because of the nature of the service. What would you do?" Unquote.
Burdett's closure would have disproportionately affected vulnerable populations, effectively increasing travel distances for maternity care, overloading nearby facilities, and exacerbating existing health disparities. Burdett serves a geographically broad population. Many residents would face sharply increased travel times if forced to deliver at alternative facilities like St. Peter's Hospital. Though it is only 8 miles away, there would be an estimated 300% increase in travel time for Burdett's affected patients. With some facing 45-minute or longer journeys, Burdett's closure would have created a dangerous delay to accessing care during labor or emergencies. Nearly 22% of Troy households do not have access to a car. in rural areas in Columbia, Greene, and Washington counties have minimal or no public transportation, especially during overnight hours. When discussing Trinity's idea to provide bus passes to laboring individuals, McDonald said, quote, "When Junior decides they're gonna go, they're not waiting for the bus to stop," unquote. McDonald continued to highlight the relationship between distance and outcomes by explaining, quote, "Adding extra distance increases the risk of a negative outcome, plain and simple," unquote.
Furthermore, the closing of Burdett would overload nearby maternal healthcare facilities. Burdett currently handles nearly 1,000 births every year. St. Peter's Health Partners provide no viable plan to absorb this volume at St. Peter's Hospital, where the labor and delivery unit was already overcrowded and under construction. Even after renovations, there would just be one additional labor and delivery room and 3 multi-use rooms, a complete inadequate expansion for the hundreds of additional high-need patients. Reports from midwives and doulas have already described chaotic conditions at St. Peter's Hospital, including births occurring in inappropriate spaces like triage rooms and post-anesthesia care units. This grossly undermines patient safety and dignity, since these areas are not designed to accommodate laboring individuals. Overcrowding has already led to delayed emergency care and the diversion of patients to unfamiliar facilities without their known providers, all of which highlight the dangerous instability of the closure plan. The claim made by Trinity Health that Burdett would be consolidated rather than closed masks the reality of an overwhelmed and under-resourced alternative. SOP described St. Peter's, the facility expected to take over services, as grossly understaffed, recalling a visit where she witnessed, quote, "women laboring up and down a hallway because they didn't have enough beds," and that was before Burdett's closure was even threatened, unquote.
Additionally, the Burdett Coalition cited numerous extensive concerns regarding the conditions such high-need patients would have been subjected to as a result of this consolidation. Trinity encouraged unnecessary labor inductions to address travel concerns, which could potentially increase medical risks. They provided unrealistic housing solutions for high-risk patients at Ronald McDonald House, a nonprofit family and children's charity which had not agreed to any such arrangement or was designed for that kind of population. They also did not suggest any viable or suitable solutions, despite maintaining that closure was the best option. The suggested surrounding alternative birth centers and facilities utilizing midwifery and doula care were at full capacity or simply not equipped to handle the demand previously served by the Burdett. Despite community resistance, Trinity Health maintained that Burdett's financial unsustainability was untenable. St. Peter's originally refused to hold public engagement meetings and only held them once they were pressured into doing so, following media coverage of this issue. Further advocacy by the coalition, consisting of petitions and a health equity impact assessment, is what ultimately led to Burdett's preservation.
Community members across the political spectrum came together to advocate for Burdett. As McDonald put it, quote, "Politics makes strange bedfellows. Ultra-progressives, moderates, conservatives, everyone agreed Burdett mattered," unquote. Ultimately, the center secured New York State grants totaling $5 million to keep Burdett open for the next 5 years. In addition to preserving the birth center, McDonald emphasized that the proposed grant funding would also enhance staff training focused on poverty, racial equity, implicit bias, and trauma-informed care. The funds would also help expand partnerships with community organizations and doula services to strengthen both prenatal and postpartum support. However, this preservation is quite fragile and temporary. McDonald says success depends on improving operational efficiency and showing better health outcomes. Future viability will be easier to argue for if outcomes continue to improve. In the last year, Burdett's C-section rate was below 20%, a 4% decrease from the average reported in the Burdett Coalition's 2020 Health Equity Impact Assessment.
Moving forward, steps have been taken to assure a future for healthcare facilities like Burdett. St. Peter's is beginning to build relationships with nonprofits to expand programs. The Catholic Church started Walking with Moms, which is a nationwide parish-based initiative to increase support for pregnant and pregnant and parenting mothers who are in need. This program will be partnered with Burdett in the coming years. Moreover, legislation has been proposed to combat the causes of maternal care facility closures. The state legislators have recently introduced Senate Bill 1226, known as the Local Input in Community Healthcare Act. It would require earlier public notice, a formal closure application including a health equity impact assessment, and a community forum held at least 150 days prior to closure. Hospitals would also be required to address community concerns in a revised closure plan before state approval. This legislation seeks to prevent abrupt service losses and ensure that vulnerable populations are considered in healthcare restructuring decisions. The struggle to save Burdett reflects broader issues within New York's healthcare system, including chronic underfunding, staffing shortages, and the challenge of balancing financial viability within community healthcare needs.
Furthermore, New York State Assembly Bill 1019 was just signed into law this past February 2025, saying that maternal health care facilities are not required to grant doulas access during emergencies or when such access could otherwise compromise the safety of the patient or healthcare team. This legislation kind of highlights the complex relationship between maternal care providers utilizing different models of treatment that yield highly different outcomes for different populations. New York State Senate Bill 2633 is an engrossed legislation which directs the Department of Health to complete a report on the impact of hospital closures on access to complete a report of the impact of hospital closures regarding healthcare access within the state. This bill would require facilities to consider the effect of closures on the surrounding community and patients before taking action. These pieces of legislation were noteworthy within our research due to their recent direct effect on maternal health care in New York State.
To address the risks within healthcare facility closures in America, our research has identified several possible solutions. This encompasses ensuring adequate accessibility in medically underserved areas. We've also noted several suggestions for their potential to improve the quality of U.S. maternal care. Reform is needed to ensure that private insurers pay hospitals in a timely manner and fairly for their services. Further reform could promote better coverage in rural areas within states with limited service coverage to begin with. Community support and extended Medicaid coverage for postpartum care can coincidingly further sustain essential services like maternity wards and raise awareness of local healthcare needs.
Standby capacity payments represent another possible solution to improve healthcare access. This approach provides steady funding when patient volumes are low. Each health insurance plan makes payments to rural hospitals based on the number of its members residing in the community. These payments cover the basic cost of maintaining essential staff and services available.
Another solution we found within our research was the Transforming Maternal Health Model, or TMAH. Introduced in 2023 by the Centers for Medicare and Medicaid Services, it aims to improve maternal care for enrollees in the Children's Health Insurance Program, or CHIP. CHIP covers children and families who earn too much money to qualify for Medicaid but cannot afford to buy private insurance. This would improve maternal care for them by reducing disparities and enhancing care quality through a whole person approach. This model is based upon 3 pillars: expanding access to care, improving safety and quality, and delivering personalized, holistic support throughout pregnancy and postpartum. It includes increased access to doulas, midwives, community health workers, and the implementation of proven safety protocols, as well as personalized care programs with remote monitoring for at-risk mothers. This model is currently being tested in 16 states and Washington, D.C., and it's going to be run for 10 years in order to examine all of its shortfalls and the efficiency of these solutions.
These possible solutions create a sense of hope for populations to see an improvement of maternal health care within the United States. Those in local, state, and federal positions of power must take initiative in advocating for effective change within the healthcare system. When analyzing the nationwide effects, it is clear that healthcare facility closures, specifically maternal healthcare closures, have a widespread impact on the communities they serve, thus revealing deeper inequalities within the U.S. healthcare system. These closures limit access to care, especially for low-income, minority, and rural populations, which forces many to travel further for essential services and increasing financial strain. They also lead to job losses in the healthcare sector and worsen existing health disparities, particularly in Black communities, which are disproportionately impacted. Overall, the trend highlights the urgent need for policy reforms to address maternal healthcare accessibility and equity across the country.
Based on our research, this trend of maternal healthcare facility closures will continue to rise within the United States unless significant government stance is made to properly address the issue. However, recent federal action has created a new threat to the existing maternal healthcare crisis, which is already under financial strain. Proposed Medicaid cuts reducing access for the already underserved populations, proposed Medicaid cuts risk reducing access to already underserved populations. The $2 trillion budget cuts approved by the U.S. House in February 2025 could further reduce healthcare resources, shift fundings to areas like border security and defense. To reverse this decline, the government must prioritize Medicaid funding and take active steps to support struggling healthcare facilities.
To conclude, our case study of Burdett Birth Center reflects a broader, growing national crisis of reflects a growing national crisis of maternal healthcare facility closures, particularly impacting access for these services for medically underserved populations. Burdett's near closure and the community's fight to save it represents the rippling effects society faces when valuable healthcare services are in danger of disappearing. The threat of closures causes significant concern within the communities that rely on these services, crafting fear of the uncertainty to come. As seen with Burdett, losing access to maternal care puts large populations at risk and increases barriers to accessing essential healthcare. When facilities like Burdett are shut down, entire regions lose vital access to safe and timely childbirth services. Similar cases are happening across the country, which is further even highlighting the urgent need for our lasting policy solutions to protect and expand maternal health care nationwide. We'd like to thank everyone for joining us here today at the Rockefeller Institute of Government, as well as all of the researchers, policy analysts, and staff who helped us with our project throughout the semester. And we'll now open the floor up for questions and our Q&A portion.
You go ahead.
Hi, I love that you guys talk to both sides in the debate, and there's realities there, right? Fiscal insolvency is real, lack of access is real, but both sides are doing the spin. Did you guys face any challenges in trying to document what was really going on, and if so, what were those challenges, and how did you overcome that documentation of the reality on the ground?
I can answer that question. Specifically kind of when it came to our interview process, like you mentioned, we're covering two very drastically different sides of the issue. Interviewing Kristen and then Ashley, both being kind of at odds within the situation, because they went about their,
Thank you. You all gave a wonderful presentation. Thank you so much on such an important issue. I'm wondering, you talked about how Burdett and New York are reflective of this broader national trend, but can you tell us a little bit about across states where New York fits into that picture with maternal healthcare access?
Sure, I can answer that. Actually, in 2020, New York ranked at 15 amongst the 50 states. Additionally, 3.2% of New York's counties are defined as medically or maternal care deserts, and that definitely is lower than the comparison to across the U.S., which is at 32.6% of maternal care deserts. That being said, there's still a lot of improvements that should be made within New York's approach to improving maternal health care. Mm-hmm.
I'll stand, but I wanted to really, first of all, commend you guys. An amazing presentation, an amazing piece of work. I'm just so proud to see how great this project has turned out, and it's so valuable. And so I'm an associate professor at Rockefeller College, and I study maternal and child health. And actually, our grant on postpartum Medicaid extensions was one of the ones that was canceled, and so I care deeply about these issues. And so one question I had was so you mentioned that you're looking into whether there's evidence about the benefits of having a freestanding birth center like Burdett. And, my understanding of all of the literature is that this is exactly the kind of birth center that we want to be encouraging if you want to improve outcomes, but we don't have a ton of evidence of how effective they really are. And to the point about what is, the sort of business model of these freestanding birth centers, I'm wondering if you looked into that at all. Are there other birth centers that maybe do a variety of different types of services so that they can, this idea that you don't have a birth every day, that may be true, but there's other services that these freestanding birth centers can provide, like maternal and child health classes or different types of services. So I guess my question is about, how much evidence do we have, if you looked into this at all, about how much better birth outcomes are at these birth centers, and can that be used as an advocacy tool to kind of push back against this idea that, it's not cost effective, or, we're not getting any benefit of having this freestanding birth center, even though all of the evidence, from my understanding, basically points to this is the exact kind of model that we should be going to. And just another point on that, there's this paradox where C-sections actually gain money for the facility, right? Because it's more expensive to provide a C-section. But from a quality standpoint, we want to discourage certainly unnecessary C-sections, right? And so there's this perverse incentive that comes in maternal health care a lot. So sorry, there's a lot to unpack there, but just really happy to see you talking about these issues.
To address the first part of your question, it actually is proven that birth centers kind of provide positive outcomes for people who attend, and that is demonstrated in the lower rate of cesarean sections, as you mentioned. But that brings up an important point about the business model of private healthcare providers. Yes, C-sections are more likely to produce negative outcomes for the mom, but they also do cost more money and therefore provide more money for this facility. And when these facilities are private, ultimately the corporation is interested in producing a profit. And when these facilities do not produce a profit, they're then closed. And this brings up a larger concern about privatization in healthcare. Ultimately, it's difficult to weigh profit incentives against the health and well-being of people, especially when we have a birth center that supports mostly marginalized communities. When you close them, you're telling those communities that profit is more important than their health outcomes or their health in general. So yeah, I think that's a really important conversation, and maybe it would be helpful to do more research in the future about privatization in healthcare and the impact on surrounding communities.
And also just to add a little bit about to Ashley's point, with Burdett and, kind of why we wanted to focus on it and why it's so significant is, because it is a facility that kind of only offers this center and focus on care. And, the issue of why we don't see so many of them and, kind of the history behind that is, a little bit about what we elaborated on. It stemmed from Black women who were not able to get access to hospitals. So, it being, a little bit more modern within medical history, starting within the Jim Crow era, It's, I guess, more recent. And I believe Ashley Slop during our interview kind of said, people today kind of view doulas as like witch doctors because it's not viewed as a legitimate, form of medical practice. And because of that, which is really why we don't see as many of them.
Hi. I had actually wanted to ask about the doulas myself because I know a lot of different cultures use doulas to bring in life and, have people leave life as well. So I was wondering after, I think it was February of this year, where it is, put into law that they're not necessarily required to be there anymore, if that's caused any issues with anybody.
Well, I mean, I guess I can start a little bit about that. It is tough to say indefinitely because it is so recent, being that it was just this past February. But, the empirical, effect of people saying that we are not necessarily required to allow you in here based on our, assumption of you being a threat does, it does pose another barrier because doulas are specifically there and provide a center on on specialized care that has a very high, or very good benefit for women of color. So honestly, yeah, I would say that we will probably be able to see that within the coming years, but that would probably be the effects that our research are pointing towards.
Hiya. I have kind of a follow-up question about doula services and these non-traditional services in general. The recent law that was passed, as you said, we don't know much about its effect yet. We also don't know much, and part of why it was passed is because in 2024, New York expanded Medicaid services to cover doula services, so that is reimbursable by Medicaid, and yet, or Medicaid, not Medicare. And yet we still see a lack of these services provided, even though there is money for them. What do you guys think is driving the lack of provision of doula services, even now that there is potentially funding for them?
I think I can take that question. As we mentioned before, services such as midwifery or doula services have this negative connotation attached to them, that they're unprofessional or like witch doctor type activities, and I think it speaks to like this larger implication around those services, that they're unhelpful, and I think the conversation surrounding that is what prevents the implementation of those services in other facilities. I think it's also important to note that doulas and midwives are often women of color themselves, and so there's also a racial element there as to why these services may not be implemented. So.
And also just to add the little bit of benefit about what, Ashley was expanding on about the larger thing behind this being that birth centers stem from supporting Black women, and health services for Black people are historically underfunded, honestly, and just, that's it really.
Okay, great. Yes, thank you so much. You guys did so well, and thank you for, sharing your research with us. You had such amazing findings. For Burdett, I think it's a really interesting case study in the sense that it didn't close. So what do you think, kind of as policymakers and people who are, academics in this space, what lessons can we take away that it didn't close?
If anybody else wants to start, because I think there's so many lessons that can honestly be learned from Burdett's case study, if you guys want to start.
I think first and foremost, what stands out to me is the lesson about consulting the surrounding community before you make such huge decisions which impact their health. A large conflict between the Rensselaer County community and Trinity Health, which was the owning corporation, was the fact that there was no notification before they decided that they were going to close this facility, which helps so many people. And so when we talk about policy and what steps we want to take moving forward, like we mentioned, there's already a bill, S1226, which necessitates that a corporation conducts a health equity impact assessment, that would eliminate the it would help eliminate the concern of like no notification, because they would first assess the impact before going and making this huge decision, and then it would also require them to notify the community of that closure beforehand, so it doesn't, make them feel like their choice was taken away from them or anything of that nature.
I honestly would say I think the most important thing going forward, if anybody were to take away anything from this presentation, is that when you give places that are under-resourced sources or resources, they're actually able to operate efficiently. Like we saw with Burdett actually being able to, improve outcomes when they were already excelling in these areas, proves this, and again, going larger to the point of, these historically under-resourced communities being put at a further detriment, really, again, the fact that these under-resourced communities really need resources, and it's not impossible to do it, honestly, Burdett is going to, I think, be fine for the next 4 years now, because, they secured a 5-year grant funding, but, one thing that we did take away from our interview with Ashley Sopp is that it's possible, again, that this could happen, honestly. It's possible that after, the time period ends, that Burdett could face closure, which, again, goes back to the cycle that we kind of have been talking about.
Right. I think to emphasize what they, Anaya and Ashley both said, I think communities have to realize that in a way for us to support facilities like Burdett, we have to provide a lot of community advocacy, because that is one of the reasons we were able to save Burdett temporarily for these next 4 years. And then we also need more of an initiative from policymakers to start pushing more and making it more of an incentive to create policies to protect these facilities, and again, continue to support their equipment and staff their wards in order to support the facility and provide access to the community.
So this semester is incredibly short, right? You guys went from 0 to this presentation in less than a semester. If you guys had another semester, what are the things that you came across that you didn't get to spend enough time on that you'd really want to dig into? Like, what's the next stage of this kind of research that you'd like to see happen?
That's a good question.
I think everyone, because, this is such a big topic encompassing so many other issues that all need to be addressed in different ways. Everyone kind of has, I guess, like their own thing that we all think is really interesting that we want to approach next.
Yeah.
I think the thing that I found most interesting was the conversation that we had with Ashley Sopp from the Save Burdett Coalition, and something that she discussed regarding, the privatization of healthcare services, and, the issue of us approaching, solving these issues with being, the way that we're providing these services isn't, the best way that we're spending our money, when the issue that honestly shouldn't be an issue. These are essential services that we need to live, yet people have to pay for them. So, I think that kind of really is something that I'm interested in expanding on, exactly what can be done about that, especially just living within a capitalistic society, honestly, where everything costs money.
I was actually going to say the same thing, just more expanding on privatization, just because I feel like all these facilities we looked at for maternal health care, they need some sort of additional funding in order to support proper staff, whether that encompasses creating more bedrooms, hiring more doulas or midwives. I just think privatization, it plays a big role on how we keep these facilities open and accessible to the public.
For me personally, I think I'd like to delve into more of the policy end of things. For our research, we focused mostly on New York because we're in New York, and so it's like relevant and accessible information for our research. But I think I'd be interested in doing a statewide case study of maybe like a state comparison of like birthing centers in other counties or states, and also what policies they have and how that influences their health outcomes, and maybe how we can implement that into New York for some of our shortcomings. Yeah.
All right. How you doing, guys?
Pretty good.
Doing great. How's everybody else?
That wasn't my question, but I'm glad to hear everything's going well. I agree with everybody who's spoken before. You guys did a wonderful job, very impressive presentation. You should all be very proud of all the work you've done this semester. I've got a kind of two-part question, more of a research standpoint. So I would love to hear first, and you did touch on this several times, about how this would the closure of this facility would impact different communities. But could you guys elaborate further on why BIPOC communities are particularly vulnerable to maternity closures? And my second question is more a positive one. As you've gone through this semester, you probably have learned a lot of things, but I would love to hear from each of you, what's one thing that surprised you that you didn't know going into this topic that you learned that you want to take going forward?
So I can address your first question. BIPOC communities are more susceptible to the harms of hospital closures for the simple fact that they are already in a predisposition to not receiving adequate prenatal care. In fact, I don't think this stat was mentioned in the brief, but Black women are 1.5 times more likely to receive inadequate prenatal care than any other demographic. And so when we have them at this standing already, hospital closures puts them even further from accessing prenatal care. And prenatal care is so essential to the birthing experience because it determines how the rest of it is going to go. And so once they're distanced from that, it just sets a bad tone for the rest of the experience. Yeah. And then for your second question, I think the most surprising thing I learned was how difficult research is, especially how it's so hard. And it changes throughout the entire process. Our research question changed 3 or 4 different times. We widened and narrowed the scope of our research so many different times. And I did not expect that. I think going in, we expected, okay, this is our research question. It's going to be straightforward. We're going to read some articles. It's going to do some interviews. It's going to be fine. And it turned into this whole different project, and we went down so many different pathways and had so many other unanswered questions, and that was the most surprising thing, I think, for me.
I think the most surprising thing for me when looking at this topic specifically was, I think I envisioned New York being one of the higher ranked states that has the most accessible maternity healthcare facilities and just providers. And it wasn't as high as I anticipated. I guess I only figured it would be because there are a lot of laws that are in place to protect reproductive rights for women, such as we still have the right to get an abortion in this state. However, I guess it allowed me to think more upon rural communities, and I mean, I'm from a very rural area, and I guess even I didn't even think of it, how significant that impact would be. This topic has allowed me to have more discussions with people from my area, and then come to find out they do travel this far to come to get maternal health care access. So I think that was one of the most surprising things I found.
I would say the most surprising thing I found, I guess, was maybe the history of birth centers. When we approached the project and, just kind of the things that we knew going in before we started conducting this aggressive or rigorous research was just that, birth centers tend to serve underrepresented communities. And, looking into the history of it and learning that it started specifically from the Jim Crow South, and, was kind of doing these things was, I guess, surprising. And it was very interesting to learn. Yeah. And I think also just a little bit to add on about the point that you asked before about, Native Americans within these underrepresented groups. When we're talking about maternal care deserts, Native Americans are one of the most impacted groups by this because so many of them live on, reservations. And the issue with this is that, a reservation is basically desert of all types of resources. And so, because so many of them live in these areas, they're so greatly affected by it.
Thank you.
Thank you.
Yes, thank you.
Thank you, everyone.
Thank you.